So let's start with introduction. What is pheochromocytoma? Pheochromocytoma is a relatively benign tumor of the adrenal glands, which secretes uncontrolled amount of norepinephrine and epinephrine. As we know, these chemicals or these hormones usually lead up to an increased blood pressure. That can be a problem. That's the major presentation of pheochromocytoma. This usually happens in middle ages. I don't want to call them old, but around late 40s and 50s. Would happen in both women and men, but there's a higher predisposition for Caucasian people than in blacks. Another thing that the examiners like to ask usually is that the association with other diseases such as 1 Hippolodin type 2 and especially MEN type 2A, which is pretty common as 50% of those have pheochromocytoma. It is also seen with neurofibromatosis. This last bit is usually seen in questions, be it in PLAB or the USMLE. Okay, so now to the major part, what we are more concerned about. When do we answer pheochromocytoma on an exam when it shows up? Usually, and this is most of the cases, but it could be different, but for the most part, classic case would be a young healthy person who is a non-smoker, is not obese, does not have any other risk factors for hypertension or high blood pressure, usually comes in repeatedly with really high blood pressures. And when I say really high blood pressures, it is not around 140, 150. This is almost in the range of hypertensive crisis, where it is the systolic blood pressure is around 190 over 200, and sometimes these guys have to be admitted in the hospital and given medication to reduce their blood pressure. And now to what we call the classic triad. This is really, it makes a lot of sense, and usually people like to come up with mnemonics or triads or just to help remember stuff. But this, what basically a patient with pheochromocytoma would present with is episodic hypertension. Usually, it's called paroxysmal because it comes and goes, but sometimes it can be persistent as well. A point to note is that this is usually the diastolic is more elevated than the systolic blood pressure. They're also accompanied with a headache, profuse sweating, palpitations, tremors, tachycardia, and tachyarrhythmia, especially like atrial fibrillation. So you can imagine people coming in with like, oh, I have racing of my heart and I'm sweating, and if they have any other history of like some stressors, people usually, or doctors in the ER usually think that they're having a panic attack, and such cases are missed. So that is something that you need to look out for. Then we come to another thing that is known for pheochromocytoma, and that's called the famous rule of 10. The rule of 10 is that most things in pheochromocytoma follow the number 10, such as even though I said it is rarely a malignant tumor, but 10% of the time it can be malignant. 10% of the times it's also bilateral, which means on both adrenal glands you would find the tumor. There's also a 10% chance that it could be extra adrenal, which is difficult to find. Usual sites of extraadrenal pheochromocytoma are the bladder and the bifurcation of the aorta. But to be honest, I don't think this information is needed for at least PLAB 1 level, but it's good to know. 10% of these are also calcified. The tumors are calcified, and we don't need to know the significance of it, honestly. And unfortunately, 10% are also found in kids. Okay, so now how do we diagnose it? How do we test for pheochromocytoma? As I said, most of the cases are usually missed because people are thought, like when they visit the ER, they think that physicians think that it is either a panic attack, something that they have heart conditions, or it's also thought that they might have hyperthyroidism. So all of these are missed. So these are some of the test findings that you would find on for pheochromocytoma. Their white blood cell count would be elevated, which is not very specific. White blood cell count can be elevated for a lot of reasons. So, but the best initial test, though, on the exam when they asked you to tell the best initial test what you would do if you suspect pheochromocytoma in a patient, then you check plasma metanephrine levels in them. A point to note is that if these are negative or not elevated, it is highly unlikely that the patient has pheochromocytoma. Whereas if they are slightly or elevated or even highly elevated, you got to confirm it with a 24-hour urine metanephrines. They used to do urine VMAs and catecholamine tests, but those are not as accurate as a 24-hour metanephrine. So if given a choice between those, always choose 24-hour metanephrines to confirm the diagnosis. Once that's done and you really suspect that the patient has pheochromocytoma, then the next step comes into imaging and finding out how big the mass is or where it is. And the first modality that you would use is a CT scan, which is pretty accurate, helps find out, and it's rather cheaper and easily accessible in the hospitals. But an MRI can be done as well, which is pretty specific too. But once again, as the slide mentions, these are only done once the biochemical tests mentioned before, such as the metanephrine levels, are positive, and this is only a confirmation test, the imaging. Sometimes, as we mentioned, 10% of the tumors are not on the adrenal glands and are extra-adrenal. So in order to catch them, or if the tumor size is too small to be caught or to be detected in a CT or an MRI, then you do something which is called an MIBG scan. It stands for something, but it is way too difficult, so I'm not going to make a fool of myself by pronouncing it. Just say MIBG, and that's what the exam would say as well. This is basically a nuclear isotope scan, which helps you detect where the location of the pheochromocytoma is. Could be a very small, once you do a radioisotope scan, they light up. On the screen, you would see where the tumor is. So it could be a very small tumor in the adrenals, or it could be elsewhere, as mentioned before, in the bladder or in the bifurcation of the aorta. Now, down to treatment options. Once you've detected that the patient has pheochromocytoma, you've done the biochemical test, you've done the imaging, now you hand the patient over to the surgical team. The surgical team, as it is a tumor, and most of the time it is a benign tumor, the easiest thing, just for like any other benign tumor, is to resect it. The resection can be done both via open surgery or laparoscopic surgery. Another thing that they usually do is they also ligate the draining vein so that it completely cuts off any remnants of the tumor. But here comes another famous exam question. What happens is they'll give you a patient that they say that has pheochromocytoma, he's going for surgery. What will you do next? The thing to do before someone goes into surgery, because there are so many metanephrines and catecholamine releases, uncontrolled releases by the body itself, you need to prep the patient by giving them an alpha blocker such as phenolbenzamine, which has to be given around 10 to 12 days prior to surgery and has to be continued. So you start with the alpha blocker, and once the blood pressure is controlled, you move to a beta blocker such as propranolol, which is given 2 to 3 days prior to the surgery, and only then the surgery is performed. If you give a beta blocker before an alpha blocker or alpha antagonist, it is going to be a big problem. So this is exam favorite, and people would ask you in what order would you give these medications. So always remember, alpha blockers come first, then beta blockers. Okay, and once you've brought down the blood pressure post-operatively, you can, or even sometimes pre-operatively, you can then move them on to calcium channel blockers if there is any signs of heart disease or tachycardia still persisting. But the bread and butter is number 1, alpha blocker, number 2, beta blocker before surgery. Okay, this once again is not very high yield. As I said, only 10% of the tumors are malignant, but just in case if someone asks you, or just for your curiosity, if they're malignant, just like any other malignancy, the solution is chemotherapy, and also radio-labeled MIGB beam radiation, where they try to locate the tumor and use radio-label rays and beams to eradicate the tumor. It is to note though that if there's a capsular invasion, or if the tumor size is bigger than 5 centimeters on CT, or greater than 80 grams in weight when you take it out and resect it, it most probably indicates that it is malignant. So that is something to watch out for, but that's mostly for surgeons, and higher level PLAB 1 would not ask you that. Okay, this is what everyone has been waiting for. What are some of the things, let's revise what are some of the things that examiners love to ask and would really want you to know about pheochromocytoma. And honestly, these are perhaps the only 2 things that you need to know about pheochromocytoma. That who has pheochromocytoma, when do you make the diagnosis? Someone who comes into the hospital has repeated palpitations, sweats a lot, is middle-aged, otherwise has no risk factors, does not smoke, is healthy, works out, does not drink alcohol, or his cholesterol levels are fine, but still has a really high hypertension, up to the level of hypertensive crisis. So the first thing that needs to come to your mind is pheochromocytoma. Secondly, as I mentioned before, and I emphasize, I think, enough on this, that before surgery, alpha blockers for 10 to 14 days, beta blockers for 2 to 3 days, and only then should you take them to surgery. Otherwise, you would have a massive problem on your hands. Okay, now on to particular questions about PLAB, and these questions have been taken from the 1700 question book. So let's break them down and see what what the real answers are. And so there are not a lot of pheochromocytoma questions in this question bank. So if someone has any, let me know. I'll try to answer them and explain you the answers. But here we have a 21-year-old woman who suddenly has onset of episodes of palpitation, sweating, nausea, overwhelming fear. On one occasion, she was woken up from her sleep. Feared she was going insane. There was no previous psychiatric disorder. What is the most likely diagnosis? So in this case, firstly, it is a young woman. 21 is not the age. We said 40 to 50 is the age. So that kind of puts us off with the diagnosis of pheochromocytoma. And then the second thing is she has fear. I mean, there is impending doom in pheochromocytoma, but fear is not really one thing. She thinks that she's going insane. She has nausea, sweating, and it is sudden. So one of the biggest thing I think over here is that she does not have hypertension. One of the biggest clues, she does not have hypertension. So and also no genetic diseases which might be associated with pheochromocytoma. So the biggest clue here is the age and also the sudden presentation. The answer over here is panic disorder, at least from what I think, instead of pheochromocytoma. Next question, 32-year-old man has been repeatedly admitted to the hospital. What is described as anxiety, panic attacks, palpitations. He is tremulous and hypertensive. A persistent weight loss is noted. What is the most probable diagnosis? Here we see, even though the age is a little younger than what I mentioned, but here we see that this might be a pheochromocytoma question, a presentation. He's tremulous, he has hypertension, palpitations, anxiety, panic attacks. He is a male. Otherwise, they do not say he has anything else wrong with him medically. So, the only thing with weight loss is that once you are producing so many catecholamines, your basal metabolism rate raises up. Once your basal metabolism rate raises up, you burn more fat and more energy, which is the reason for weight loss. So over here, I would say pheochromocytoma is the answer. Generalized anxiety disorder would have not only panic attacks, but also other forms of anxiety. Hyperthyroidism would have other features such as heat intolerance. Panic attacks would be sporadic, and would not have hypertension. So that just basically leaves us, and Cushing disease is a total different thing. There would be way more symptoms than just the mention. So here the answer would be pheochromocytoma. And this third question says 43-year-old woman has been feeling lethargic, tired. Her BP is 160 over 90, blood work shows sodium 140, potassium 3.1. What is the most likely diagnosis? They're saying renal disease, they're saying hyperparathyroidism, Cushing's, Cushing, and pheochromocytoma. Now, all of these are endocrine problems. So, they're just giving you some options which might confuse you about as to what endocrine issue is going on over here. So, in this case, we see that the answer is Conn's syndrome, because usually Conn's is in women, mostly seen in middle-aged women. Conn's has higher blood pressure, even though they don't mention kid here, and as I said, pheochromocytoma would be way higher blood pressure. Pheochromocytoma does not have lower potassium levels. Con syndrome is due to hyperaldosteronism because there's low plasma renin. So there'll be tetany and other stuff, and the only common thing between them is that there's refractory hypertension. So this is, you need to know that the electrolyte balances are different here, and that's the clue that this is not pheochromocytoma, and instead this is Con syndrome. With that, I conclude my first video. I'm really sorry, I don't know if how good a job I did with this. I'm still new to this. I'm trying to help others as I learn myself. As I mentioned in my post, if you have any questions or any topics you want me to cover, feel free to either leave a message under the video. I'll upload it on Facebook and YouTube. And if you have any suggestions or want me to cover a particular video, I've left my email address over here. You can email me and give me your feedback and suggestions. So thank you for bearing with me. I know this has been a little longer video than it should have been. Next time I'll keep it precise, and you guys can let me know what I should cover and how long the video should be, and that's pretty much it. So thank you so much for watching, and hopefully I'll keep on bringing you more and better content. And good luck for those who are preparing for your exams. Study hard.